Dear candidates, good day to you all. This lecture is one in my series on the anatomy of the ocular adnexa, and this one in particular is on anatomy of the orbit. And as you all know, the orbits are two big cavities situated on the front and the upper part of the skull. Each orbit looks like a cone, but this cone is truncated. Truncated meaning not with a very sharp tip and situated on its side. Each cone has 4 walls and a base. 4 sides, 4 walls and a base, and the base is directed forwards as the cone is on its side. Both cones have 4 walls, as we said, and the medial walls of both orbits are parallel, while the lateral walls are converging into a virtual point behind both orbits, and this virtual point is a 90 degrees angle. Now, on viewing the skull from a side view, you can notice that the medial wall goes more forwards than the lateral wall, and this exposes the orbital contents. This lateral exposure is a sort of a disadvantage in case of trauma, but at the same time, a sort of an advantage on performing surgery, as this side is the most accessible one. Now, again, to sum up, the orbits are conical structures that not exactly angular, but the walls are regular and curvilinear. The apex is posterior, the base is anterior, and there are some thick bones, but the walls are thinner. The medial wall is parallel to the sagittal plane, extending more forward, and the lateral wall is shorter, convergent, more recessed, and both are meeting at a virtual rectangular angle point behind both of the orbits. Now, from the applied anatomy point of view, pressure to the eye is dispersed to the 4 walls, and this leads to absorption of forces and protection of the globe. However, some of the walls, especially the medial wall, as we'll see later on, may fracture easily. The lateral wall, as I said, is more recessed backwards, and this facilitates peripheral vision, gives access surgically. And the conical design in itself maintains position of the globe without mobility in a case of acceleration. This is a transverse view of both orbits on a CT scan. You can see both medial walls parallel, both lateral walls converging behind the orbits. This is virtually dividing the 4 walls and letting them gather together. And continuing with the configuration, the orbit is 40 millimeters wide, is 35 millimeters high, with the widest circumference inside the rim, meaning the aperture is 40 millimeters, but behind it there's a sort of a dip, and the circumference is 45 millimeters. The medial wall is 45 millimeters deep. The lateral wall is only 35 millimeters deep, making it recessing backwards a bit. In children, however, the orbits are rounder, and with passage of age, there is an increase in the width. So, in children, a round orbit and a squared orbit in adults. Here is the child skull, and this is the adult skull. Now, the orbit is formed by 7 skull bones. These are the frontal bone, the sphenoid bone, the zygomatic bone, the ethmoid bone, the lacrimal bone, and the palatine bone. The orbit has two fissures. These are the apertures where structures gain access into and out of the orbit. The superior orbital fissure, which is black on the right, red on the left, and the inferior orbital fissure, which is blue in color. The bones that form the orbit are 4 external bones and 3 internal bones. The 4 external bones are the frontal bone, which is a single midline bone, the zygomatic bones, which are 2, the maxillary bone, which is a single midline bone again, and the lacrimal bones, which are 2. If we dismantle the skull, we find there are 3 more bones that form the orbit. These are the sphenoid bone, which is butterfly in shape, with a central body and 2 lateral wings on each side, the smaller wing of the sphenoid or lesser wing of the sphenoid and the greater wing of sphenoid. And the ethmoid bone, which is a single midline bone, and finally the palatine bones, which are 2. For further understanding of the structure of the bony orbits, here is an animation of the human skull formation. The human skull is formed of 8 cranial bones, as well as 14 facial bones, which give the structure of the face and support the teeth, with the mandible as the only mobile bone in the skull. All bones of the skull articulate together in the sutures, and the skull has foramina, which are holes giving access to the vessels and nerves. The bones of the skull protect the brain, the sensory organs, and give attachment to the head and neck muscles. Now, the skull externally is formed of the occipital bone, the parietal bone, the temporal bone, the frontal bone, the nasal bones, the zygomatic bones, the maxilla, as well as the mandible. If we dismantle the bones of the skull, we can see the first internal bone that shares in the formation of the orbits, and this is the sphenoid bone. The sphenoid bone makes the anterior base of the cranium and is a butterfly-shaped bone with a central body and 2 laterally projecting wings, the lesser wing and the greater wing. On its middle, there is a depression called the sella turcica, and this lodges the pituitary gland. Another bone that appears on the inside of the skull is the ethmoid bone, and this forms a portion of the cranial floor and roof of the nasal cavity. An inferior projection of the ethmoid bone, the perpendicular plate, forms a part of the nasal septum. The crista galli projects anteriorly from the ethmoid bone and serves as attachment for the falx cerebri. Extending laterally from the crista galli is the cribriform plate of the ethmoid, which is a perforated bone through which fibers of the olfactory nerve pass. The 2 palatine bones are L-shaped and form the posterior part of the hard palate, part of the nasal cavity, and the orbit. The lacrimal bones form parts of the medial walls of the orbit. It features a lacrimal groove that lodges the nasolacrimal duct. In addition, the vomer is a plow-shaped bone that forms the inferior and posterior parts of the nasal septum. All the internal and external bones of the skull articulate precisely, making a robust structure perfectly suited for its function. Now, the orbital walls are the roof, the floor, the lateral and medial walls. They come together to form the orbital box. The roof is formed of the sphenoid and frontal bones, the medial wall of the lesser wing of sphenoid, the ethmoid, the lacrimal and frontal process of the maxilla, the lateral wall of the frontal, zygomatic and greater wing of sphenoid, and the floor is sphenoid orbital process of the palatine and orbital process of the maxilla. Now, the lateral wall of the orbit being formed of the frontal bone, the zygomatic bone, and the greater wing of sphenoid. It's the least proceeding forward of the walls, facilitating lateral vision, and its zygomatic portion is very thin, and it thickens considerably at the site of the sphenoid where it borders the superior orbital fissure. The floor of the orbit is formed of the sphenoid bone, the orbital process of the palatine, and the orbital process of the maxilla. From the inferior rim, the floor dips inferiorly for 15 millimeters past the inferior orbital fissure, and then gently curves up once more to the superior orbital fissure. There is a clinical significance of this fact while repairing the orbital floor fractures and while giving peribulbar anesthesia. On injecting anesthesia peribulbarly, the needle should consider this dipping down and then goes up again to avoid perforating the globe. This is how it goes. The needle goes along the dipping and then posteriorly. The medial wall of the orbit is formed of the lesser wing of the sphenoid bone, the ethmoid, the lacrimal, and the frontal process of the maxilla. The medial orbital rim is less defined than the other rims, and the entire wall here is thin and is called the lamina papyracea. It's strengthened by perpendicular septa of the ethmoid sinus, and it separates the ethmoid sinuses and nose from the orbit. The roof is formed of the frontal bone and the sphenoid bone, and it curves up in lateral aspect to accommodate the lacrimal gland, separates the anterior cranial fossa from the orbit. It is thin and becomes even thinner with age. The superior rim has supraorbital notch on the medial third and sometimes calcified, forming a foramen. To sum up the structure of the skull and orbits, here we go with the 8 cranial bones and the 14 facial bones forming the structure of the face, carrying the teeth, and the mandible is the only mobile bone. The different bones come together articulating at the sutures, and the foramina give access to and from the skull for vessels and nerves. The bones in this way protect the brain and the vital organs, sensory organs, and the skull externally is formed of the occipital, the parietal, the temporal, the frontal, the zygomatic, the lacrimal, the maxilla, and the mandible. Dismantling the skull shows us the internal bones, the first of which is the sphenoid bone with its body in the middle and the lesser wing of sphenoid and the greater wing of sphenoid on the lateral sides. On its top part, there is a depression called the sella turcica that lodges the pituitary gland. Another bone is the ethmoid bone with its perpendicular plate forming a part of the nasal septum inferiorly and extending anteriorly. There is the crista galli that gives attachment to the falx cerebri with the two cribriform plates of ethmoid on both sides, perforated plates giving access to the olfactory nerve fibers. Then come the palatine bones, L-shaped bones, forming part of the medial wall of the orbit, and then the lacrimal bones, forming again part of the medial wall of the orbit with a groove for the nasolacrimal duct called the lacrimal groove. Then comes the vomer, which is a midline bone forming the inferior and posterior parts of the nasal septum. All bones, internal and external, come together in a very miraculous, robust structure that serves its very high superior function. This slide here shows a frontal view of the orbit where the foramina are shown. This is the left orbit, and number 5 is the optic canal, number 6 is the superior orbital fissure, and number 9 is the inferior orbital fissure. Number 21 is the anterior ethmoidal foramen, number 20 is the posterior ethmoidal foramen, number 1 is the supratrochlear canal, and number 2 is the supraorbital fissure, number 11 is the infraorbital fissure, and number 19 is the foramen of Hertel. The Whitnall's tubercle is a particular structure. It's a protuberance found on the lateral orbital margin. It's just inferior to the frontozygomatic suture, and it serves as an attachment for the lateral canthus. A view of the cranium from inside after cutting off, removing the vault of the skull, you can see the anterior cranial fossae, which are two, one next to the other, the two middle cranial fossae, and the posterior cranial fossa. The anterior cranial fossa is directly related to the orbits through the roof of the orbit, which is formed here by the orbital plate of the frontal bone. The middle cranial fossa receives the optic nerve via the optic foramen, and the posterior cranial fossa is characterized by the presence of the foramen magnum, which is number 31 here. The orbital foramina, to be enumerated, these are the superior and inferior orbital fissures, the optic canal, the anterior and posterior ethmoidal foramina, and the cranio-orbital foramen or foramen of Henle. The superior orbital fissure is a club-shaped structure situated near the apex of the orbit, and by club-shaped we mean just looking like a golf stick. It is situated where the greater and lesser wings of sphenoid bone meet the maxilla, and it gives passage for the lacrimal nerve, the frontal nerve, trochlear nerve, the superior division of the ophthalmic vein, the nasociliary nerve, the inferior division of the ophthalmic vein, and the abducens nerve. These, in arrangement, can be remembered by memorizing the mnemonic LFTSNIA, referring to the phrase live free to see no insult at all. Actually, fractures, edema, or hematoma at this fissure lead to ophthalmoplegia, ptosis, plus or minus pupillary dilatation, and this condition is clinically referred to as superior orbital fissure syndrome. The annulus of ZINN, also called the annular tendon or the common tendinous ring, is a ring of fibrous tissue surrounding the optic nerve at its entrance at the apex of the orbit. It gives common origin for all the recti muscles, the levator palpebrae superioris, as well as the superior oblique muscle. Actually, to all extraocular muscles except the inferior oblique. It divides the superior orbital fissure to above the ring, within the ring, and below the ring, and it is actually a condensation of the dura of the canal at this area, the dura of the optic canal. The inferior orbital fissure is 1 centimeter posterior to the inferior lateral rim. It connects the pterygopalatine fossa with the floor of the orbit, and it is composed of the zygoma and sphenoid on the lateral side and the zygoma and the maxilla on the medial side. In its anterior portion, the infraorbital canal runs anteriorly through the floor, exits on the maxilla 5 mm inferior to the rim in its middle. The branches transmitted through it are the small dental branches, that is the anterior superior alveolar and middle superior alveolar nerves. The artery that passes through it is the terminal branch of the internal maxillary artery, and the vein it drains into the pterygoid plexus. The optic canal lies medial to the superior orbital fissure at the orbital apex. It's 5 mm in diameter. It runs in a superior medial direction into the middle cranial fossa. It's less than 1 centimeter in length. It lies entirely within the body of the sphenoid. The walls of the canal can be thinned in some individuals by proximity of the sphenoidal sinus, and the optic nerve and ophthalmic artery pass through it, and fractures extending to the optic canal can result in a condition of loss of vision plus superior orbital fissure syndrome, a condition called orbital apex syndrome clinically. The anterior and posterior ethmoidal foramina are two foramina located on the medial orbital wall. The anterior is 15 mm behind the medial rim. It exits at the level of the junction of frontal bone with the ethmoid bone into the orbit, and it transmits the anterior ethmoidal artery. The posterior ethmoidal foramen is 1 centimeter further posterior to the anterior ethmoidal foramen, and it transmits the posterior ethmoidal artery, and both have been recently described as sources of epistaxis and sometimes bleed during the operation of orbital exentration. This is the anterior ethmoidal foramen on the left orbit, 15 millimeters behind the anterior orbital rim, and 10 millimeters behind it is the posterior ethmoidal foramen. The last of the foramina of the orbit is the CRANIO-ORBITAL foramen, or the foramen of Henle. It lies on the lateral orbital wall just anterior to the superior orbital fissure. It gives passage to an artery that represents an anastomosis of the middle meningeal artery with the lacrimal artery. It has drawn recent attention as it is a potential of hemorrhage during decompression surgery or during deep orbital dissection surgeries. It exists in 55% of specimens only. Needless to say that the orbital contents are the globe, the fat, the lacrimal gland, the extraocular muscles, the intermuscular septa, the ciliary ganglion, the nerves and vessels, and the periorbita. And here we have to describe the periorbita. It is a the periosteum of the orbital cavity that is continuous with the dura around the optic nerve. It similarly continues with the dura of the foramina through the superior orbital fissure, the anterior and posterior ethmoidal foramina, and the cranio-orbital foramen. It loosely attaches to the bone compared to the periosteum of the facial bones, and it extends to the eyelids in continuation with the orbital septum. Another structure that has to be described is the Lockwood ligament. It's the suspensory ligament of the globe. It is the thickened lower part of the tenon's capsule. It blends with the lateral canthus and the lateral check ligament, transversing from lateral to medial. So it serves like a hammock under the globe. So it suspends and resists anterior-posterior displacement of the globe. On the medial wall, it attaches to the anterior lacrimal crest and blends with the canthus and medial check ligament. On the floor, the inferior oblique and the inferior rectus cover the inferior orbital fissure, and here they serve as inferior check ligaments for the globe. At the roof, the superior check ligament is the fascia of the levator palpebrae superioris muscle, and on the lateral wall, it's anchored at the WHITNALL'S, tubercle, and medially to the trochlea. It has got 4 extensions, and these are the arcuate ligament, the capsulopalpebral ligament, the ligament or the check ligament of the inferior rectus, and the conjunctival fornix. Capsulopalpebral ligament is described in the lecture on eyelids as the inferior or part of the inferior retractor, that is the lower lid retractor, the analog of the levator palpebrae superioris in the upper lid. We come now to the orbital fat, that is the pads around the globe, and these are divided into extraconal and intraconal. Extraconal fat is that fat outside of the cone of muscles. It facilitates the movement of muscles, serves as a cushion, and is contained by the periorbita. It does not contribute to position of the globe and is reduced during the operation of blepharoplasty. Its excision does not lead to any sort of enophthalmos. So it doesn't serve, the extraconal fat doesn't serve in positioning of the globe within the orbit. On the contrary, the intraconal fat contributes significantly to maintenance of the globe position, and its loss may cause enophthalmos. The ciliary ganglion is an important structure within the orbit. It's a parasympathetic ganglion, one of the 4 sympathetic ganglia in the head and neck. The others are the submandibular, the pterygopalatine, and the otic ganglia. It's located in the posterior orbit at the angle between the superior rectus and the lateral rectus, 1 millimeter in diameter, containing 2,500 neurons. It has got 3 roots, just like any ganglion: parasympathetic, sympathetic, and sensory roots. And the parasympathetic roots come from the 3rd nerve, which are the preganglionic axons from the Edinger-Westphal nucleus of the 3rd nerve. These synapse in the ganglion, and the postganglionic axons run in short ciliary nerves to sphincter pupillae and ciliary muscle. The sympathetic roots come from fibers around the internal carotid artery, that is the internal carotid plexus, and pass within the ganglion without synapse. The sensory roots come from the nasociliary nerve and the ophthalmic nerve. Here the structure of the orbit. The bone is filled with muscles, veins, arteries, nerves, fat lobes, the globe and the extraocular muscles, the lacrimal gland, the ciliary ganglion, the extraconal fat, and finally the skin. On a sagittal view, we can see the globe with the extraocular muscles, interconal fat, extraconal fat, all the vessels, nerves, and periorbita, and finally the lids with their mobile structure. Here, this is a dissection of a cadaveric orbit where from the view inside the cranium, the roof of the orbit has been removed. And on your left side, this is the right orbit where you can see number one is the superior oblique muscle turning at the trochlea, number two, and taking a different direction to insert into the upper part of the globe. Number four is the levator palpebrae superioris, and number five is the globe. Number six is the severed lateral rectus. Number seven is the lateral rectus. Number eight is the superior rectus, and number nine is the common origin on the annulus of ZINN. On your right side, this is the left orbit, and it's showing the same structures, where number 16 is the lateral rectus, reflected and cut, and you can notice number 17 as the ciliary ganglion located at the angle between the superior rectus and the lateral rectus. And number 2 is the lacrimal nerve. Number 5 is the frontal nerve, and number 6 is the nasociliary nerve. This is the same view but with both orbits, where you can see the globe and the muscles, and number 1 here is the lacrimal gland, number 2 it's palpebral lobe, and here this is a lateral view of orbital dissection, where you can notice the 1 and 2, number 1 and 2 as the two lobes of the lacrimal gland, and this green probe here is showing the site of the ciliary ganglion, and here's the frontal nerve, number 8, and number 4 is the levator palpebrae superioris muscle, and I'm expecting more details of these dissections to be demonstrated in practical sessions. This is another lateral view of the orbit showing the sella tertica, number 13, where the pituitary gland is lodged. Number 12 is the anterior clinoid process. 14 is the posterior clinoid process. Number 7 is the lateral rectus attaching to the globe. Number 6 is the inferior oblique muscle taking origin from the roof, from the floor of the orbit and attaching to the globe. Number 16 is the inferior rectus, number 8 is the superior rectus, and number 4 here is the levator palpebrae superioris. Now this is a cast of the vessels showing you how dense the vessels are, and here all the veins of the orbit are drained through the facial vein, and these are the complex plexuses of veins in the face. Now here, this is the skull from inside, showing the different venous sinuses from posterior to anterior, and these are the transverse, the sigmoid, the jugular, the inferior and superior petrosal, the basilar, the cavernous, the intercavernous, the sphenopalatine, and finally the straight. This here is the transverse on behind and the straight on the front. Now we come to the final point in this lecture, which is orbital imaging anatomy. This is a plain X-ray postero-anterior view of the skull. And This view has particular markings which are numbered here. As you can see, number 1 is the crista galli. Number 2 is the lesser wing of sphenoid. Number 3 is the zygomatico-frontal suture on the lateral orbital rim. Number 4 is the superior orbital fissure. Number 5 is the nasal septum. Number 6 is a line, is not an actual anatomy, but it shows on this view as the inner wall of the temporal fossa. Number 7 is the superior margin of the petrous ridge, and number 8 is the maxillary antrum. Here again, this is the crista galli. This here is the lesser wing of sphenoid, having its share in the medial orbital wall. This is the suture between the zygomatic bone and the frontal bone. This number 4 here is the superior orbital fissure, looking like a dark shade. This is the nasal septum, and this is the line formed by the inner wall of the temporal fossa. Number 7 is the superior margin of the petrous bone intracranially, and finally number 8 is the maxillary antrum. Now this is a CT scan with the globe looking upwards. As you can see, this is the crystalline lens. The levator palpebrae superioris may be shown as a complex with the superior rectus and the optic nerve. Also, the inferior oblique and the inferior rectus can be shown when the globe looks down. This transverse section, and actually there is pathology here on the right orbit. Now this is a coronal section, and in coronal section we can see the extraocular muscles in section. And this is a three-dimensional composition of the different views of the orbit. Another transverse section of the two orbits, a coronal section showing the muscles. One method of imaging of the orbit is B scanning, ultrasound, and this can show the extraocular muscles and the W shape of the optic nerve and the globe vitreous cavity where the probe is placed anteriorly. Thank you very much.